I appreciate everybody's patience. I'm hoping that everyone online can hear and everybody in the room can hear and everybody's seeing the slides, and we're going to go from here. So welcome to the Innovators for Health Equity and Racial Justice Speaker Series. I'm Allison Bauer. I'm Associate Chair of the Health Science and Public Health and Health Science Department, our new name, as well as an Associate Teaching Professor. It is Public Health Week. It's day 2 of National Public Health Week, and this is part of our inclusion of activities. So I'm going to do a quick introduction, which is really hard to do, a quick introduction of our speaker, Dr. Monica Bharel, because her career is pretty phenomenal. So I'm going to read notes because I cannot remember all of this, and then we'll hear from her, and then we'll have some time for questions both in the room as well as for people watching online. So Dr. Monica Bharel is a senior public health advisor, helping technology companies solve public health challenges using the power of data and analytics to drive innovations and advance health opportunity for all. She's currently working at Google Health as part of the Population and Environmental Health team, the Mental Health Center for Excellence team, and the Cloud Public Sector team. She previously served as a senior advisor to the mayor of Boston and was appointed by Mayor Wu to lead the city's response to the humanitarian crisis at the area well known as Mass and Cass, especially to many of us here at Northeastern. She oversaw a public health and equity-led approach that focused on individual medical and treatment needs. This transformative process has included offering low-threshold housing and shelter options to unsheltered individuals, with a focus on building intermediate and long-term plan to address the intersecting issues of homelessness, substance use disorder, and mental health. She previously served as commissioner of the Department of Public Health and was the Commonwealth's chief physician from 2015 to 2021. I'll go off script a little bit to say that's when I had the opportunity to work for her at the Department of Public Health. She helped lead the state's aggressive response to the opioid crisis and was dedicated in reducing health disparities and addressing a data-driven, evidence-based solutions to keep people healthy. She also led Massachusetts' public health response to the COVID-19 pandemic. As commissioner, Dr. Bharel oversaw a workforce of nearly 3,000 people and had expansive department issues from environmental health to injury prevention to infectious disease. And under her leadership, Massachusetts ranked nationally as one of the healthiest states in the nation. She is a board-certified internist who's practiced internal medicine for more than 20 years at Mass General Hospital, at Boston Medical Center, at neighborhood health centers and the VA. She served on the faculty at Harvard Medical School, at Boston University Medical School, and Harvard School of Public Health, and has been recognized for her dedication and commitment to helping vulnerable populations. And prior to becoming Commissioner of Public Health, she was the Chief Medical Officer at Boston Healthcare for the Homeless. She has her master's in public health through the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. Her medical degree is from Boston University, and she completed her residency as well as chief residency in internal medicine at Boston City Hospital, now known as Boston Medical Center. Never has any boss ever made me feel less qualified to do anything in my life. With that, I'm going to hand you over so you can hear from Dr. Bharel about the work that she's been doing and specifically speaking to health equity.
Hello, lovely to be here with all of you today. Can you hear me okay? Thank you for your patience. Thank you for joining us online and for joining here in person on this beautiful April day. I wish it was April Fool's Day. I'd paste like a little joke on you, but I don't know if I could think of one. So great to be here with you. And Professor Bauer, thank you for that generous introduction. Allison and I had the chance to work together, particularly on substance use disorder. So I hope you get a chance to expose yourself to her and learn from her, because it's a great opportunity that you have here for the students to be exposed to her. When she asked me to come and talk about health equity and racial justice, I decided I would talk about everything and take you through that trajectory that she just told you on how I have used the levers in front of me to pull and make change as it relates to health equity and finding the levers where you can. Due to our slight technical problems, by the way, I came in here saying there's no way I can cover this in the time allotted. And my husband, who also does a lot of talks, said, you know, you should fit your talk into the time that people give you. And I already didn't do that, and now we're going to do it in a shortened time. But we're going to go on a whirlwind tour because I want to give you a sense of ways in which you can pull levers, especially for the students as you think about your current roles and things you want to do in the position. We are always, each and every one of us, no matter what we are doing, we are always in a place where there is a lever we can pull that pushes us towards the arc of equity and towards equity. And that takes persistence and resilience. It takes patience, it takes hope and optimism, and definitely a sense of humor. So let's go a little bit on that journey. I'm going to take you through some work that I have done. Hello. I'm going to take you through some work that I have done in the various roles that you've heard about. I'm going to talk to you a little bit about my patients, about Boston Healthcare for the Homeless. I'm going to take you to the Department of Public Health with me to address the opiate epidemic, to address COVID, through the mayor's office, and then to the current work I'm doing at Google. And part of what I want to talk about is how we can use, each one of us, the data that we have in front of us and the data that maybe some of you are on your way to research, the data that we collect to then understand more deeply the determinants of health and use those to impact disparities. I'm going to put a lot of data in front of you. I'm going to put a lot of data in front of you, and I want to start with grounding us in relationships because we're about to jump into data. My relationships and understanding of this work in health equity starts with my dad, who just passed away, so I dedicate this to his memory. And he was a physician who loved what he did and served his patients with courage and dignity and showing them the respect that they need, even when they couldn't pay for the services they had. And then it's my patients. My patients have always been my best teachers and have reminded me again and again that as we work towards health equity, it is our imperative to think about the people that we believe that we are serving and understand and ground our work in what they need. I was at Boston Healthcare for the Homeless throughout my residency and then formally in different leadership positions for 12 years. In my last year at Boston Healthcare for the Homeless, I started asking my patients this question. And even now, I'm not sure why I started asking this, except that I am an internal medicine physician, and I had learned and spent my life practicing the art of medicine. And I knew the algorithms for diabetes and hypertension and how to treat them and what to advise people to do. And yet my patients kept coming in and again, were people experiencing homelessness and were having trouble controlling these chronic diseases, being able to manifest health. So I asked them, what will it take to make you healthy? And even after working with people experiencing homelessness for over 2 decades, I was surprised by the answers. Some of them said, what it takes to make me healthy is the diabetes prescription that you give me, the medicines for the prescription, or you referring me to the cardiology. But I think they were mostly being polite. The vast majority of people, the vast majority, said something very different. They talked about connecting to their families. What will make you healthy? Seeing my children again, having a safe place to sleep at night, having access to the food that I know I need to eat to take care of my medical condition. And that became an insight for me on if I wanted to address the health inequities that I was seeing in the people that I was serving, I had to get out of the clinic room and look beyond to this broader sense of what health is and how health is impacted, how health is impacting them. So now talking to ground us all, especially for the students, I believe you've seen some of this, but what is this concept of health and how does it relate to what we're talking about today? So I hope you've seen some version of this before, but if you haven't, for the students especially, if you take one thing away, take this away, that our health is way beyond the healthcare that we provide. I'm a dedicated medical physician, and yet the health of my patients, only 10% is related to the actual healthcare they get, especially in that broader definition that our patients teach us. And then there's biology and genetics, but look at the rest of it. It's about our built environment. It's about our physical environment. It's about behaviors, and it's about our social and economic factors. So how, for those of us concerned with improving health for individuals and helping them reach their health priorities, do we impact that? Another way I wanted to make sure you've seen this, I'm very visual, and this helped me along my journey. This is from American Journal of Public Health, now 2010. And this is the CDC Health Impact Pyramid. And if you look at it, so this is looking at a population health level, what impacts health? And what I was doing in my clinic room is at the top. At an individual level, that has efficacy. But when we're looking at an entire population and how to impact their health, and only a small part of that is the counseling and education that I can give my patients or the clinical interventions like that blood pressure medicine. And at the bottom of the pyramid is where we can have the greatest impact when we look at the socioeconomic factors and changing the context that people are in so that healthy choices are easier to make. Healthy choices are easier to make. I remember a patient when I was an intern back in 1994. My clinic was at Dorchester House Neighborhood Health Center. It was very unique then to have people go from academic medical centers out into community health centers. And I loved being a doctor, and I was there always late at night talking to my patients. And it was late in the evening. There weren't many of us left. And I was talking to a woman about her obesity, high blood pressure, and diabetes. And I gave my usual spiel at the top of that pyramid and was talking to her about eating right. And I was really proud that I understood the guidelines. I knew how to take care of patients. And she set me straight in a way that this is now, we're talking many years ago, and I'm still grateful to her. She said, "Doctor, with all respect, I know those things. If I were to do what you were telling me to do, you would see that it is impossible. You're asking me to go for walks. I work 3 jobs in order to put food on the table. If I walked in my neighborhood at night, it's too dangerous for me and my children. You're asking me to eat certain foods. I budget my food very carefully. If I ate what you were telling me to eat, then the money would run out to feed my children by the middle of the month." And so on and so on. People know what it takes to be healthy. People understand. But is there an opportunity for health? And what policies are contributing to people not being able to reach that? So that this top of the pyramid on a one-on-one level can be achieved only if we understand this full context of what an individual is experiencing. This is from the Bay Area Regional Health Inequities Initiative. There's a lot on this slide. I want to point you to the right-hand side where you'll see the things that we take care of in the healthcare system: disease and injury, and preventing premature mortality. And when you have a disease or illness, there is nothing like being able to get that treatment. But that is a small part of the spectrum of what health is. You go up further to risk behaviors, right? We're moving upstream to living conditions, which I was just talking about. But then you can go even further upstream from that. So whether or not your focus is on health, there are ways to address institutional inequities and social inequities that ultimately lead to these disparities that we see when someone is in a clinic room sitting across from their professional provider. If it's not enough to say that let's provide equitable care to all, let's get more practical. The US, I hope the students all know these facts too. If you go to the Commonwealth site where I pulled this from, there's fascinating details on this. The US spends more of our GDP than any comparable country, almost 18% on healthcare. Remember, this is healthcare, not that broader image of health that I showed you. But yet, if you look at any indicator of quality of healthcare, look at life expectancy, and you'll see that among the OECD countries, we are the lowest. So you could say, you know what? We have decided as a country, as a healthcare policy, that it's okay that we're spending almost 18% of our funds on GDP, because look at our population. People are so healthy, and it's worth it. But yet, after outcome, I've only chosen life expectancy here. You see that even though we spend so much, we're some of the unhealthiest people among our comparative peers. So what is missing? And we know that when you look at this as a population level, you'll see that individuals who need services the most, when we have blanket health policy things, it is always those of us who need it the most who have the worst capacity to access these improved outcomes. When I was at Boston, hello? When I was at Boston Healthcare for the Homeless Program, we were working to think about people experiencing homelessness specifically, and how to think about their care and how to work that into value-based systems and other things that were happening in the mid-2010s. If you look here, data from that time showed even within the United States, Massachusetts spent more on healthcare than any other state. And in 2022, we're still among the highest in terms of where we spend our funds. And that funding, especially when you're talking about public programs, that funding doesn't come from nowhere, right? So there is a connection to issues that affect our health. This is how we broke it down. So when we increase our spending, it is a finite bucket. So when we increase spending on healthcare, we decrease spending in areas like public health, mental health, education, and so on. It's a finite bucket, and we're making choices as a society from a health policy point of view of where to put these funds. And if you see that first bucket of public health, before COVID, I used to explain why that matters and why we were underinvesting in the United States in public health for decades. I don't need to do that anymore. We saw the impact of what it was like to underinvest in public health during the COVID-19 pandemic. We connected this information to patients experiencing homelessness and published a paper related to homeless individuals in the American Journal of Public Health. Some of the key findings there were even among individuals who were using Medicaid, the cost of caring for someone experiencing homelessness was skyrocketed based on their medical illness. So think about the money we're spending in healthcare and what it would cost for one of these interventions to go upstream from this, as I showed you in some of the past pictures. And then one of the most powerful things we found was that individuals with substance use disorder or with a mental health issue had some of the most expensive costs in the system. What we did with this information at Boston Healthcare for the Homeless is we redesigned the way we saw patients so that there was more of a focus on the behavioral health needs in addition to the medical needs. And then we started seeing impact in there. But the data, what I said to you before, data to look at the social determinants, to find the disparities, this kind of information helped us locally and at the state level to say we need funding in different places within a high-risk population in order to care for them better. Now let's move on now to the Department of Public Health. When I was at the Department of Public Health, we crystallized this approach to thinking about disparities through the lens of using data that we have available to us and looking at the social determinants of health, and then understanding disparities and how we can impact them. We called this the Department of Public Health House. For the time that I was at the Department of Public Health, everybody knew what this house stood for and their role in it. So codifying the vision of how we would address health equity. And that was taking the data. The state collects a massive amount of data. Taking that data and truly using it to understand the determinants of health and find disparities, and then targeting our limited resources. You saw the public health resources in one of the other slides I showed you. Targeting those limited resources to where they will have the greatest impact. And to that end, within our vision at the Massachusetts Department of Public Health, which is around these things I'm talking to you about, being data-driven, evidence-based, providing services, we added something, which was the eradication of health inequities. Those of you who have been following these series of talks have heard from Dr. Thea James, and she talks about intentionality. And intentionality is really important when we're talking about equity. It cannot be presumed. It cannot come along with a package of other work. It has to be intentional. And the intentional vision of the Massachusetts Department of Public Health was to eradicate health inequities. And we used the structure I showed you of the Mass DPH House to go towards that. A case example of that we had an opportunity to work on earlier that Professor Bharel also worked on us with is around the opiate epidemic. In 2015, the governor's primary, #1 health priority was addressing the opiate overdose epidemic and the deaths that were resulting from it. That led us to an opportunity to put our framework into action. We knew that blanketing services across the state of Massachusetts would lead in some improvement, but also when we blanket services and don't intentionally pay attention to those of us who need them the most, and for those of us who it's hardest to achieve, we widen disparities. So we went on a really focused journey in order to do that. And one of the first things we did was we said, we've been trying to address addiction for decades now, and it's not working. How can we do something differently, and what information do we need to know that? And what we did then was we built a public health data warehouse. You see these different silos, they're different pieces of data that live at the state level, some at the Department of Public Health, some at other agencies. And us as individuals, we have data in multiple different places, but these data silos can't speak to each other, and they can't communicate to have a holistic picture of how any one of us is experiencing our substance use disorder disease. So we worked to build an integrated data system to be able to truly understand from a broader health picture how someone who is experiencing substance use disorder goes through our system and where there may be some weak points where we need to change the way that we put our interventions in place. If you're interested in learning more on the Department of Public Health website, there are many policy guiding decisions that we put out and data reports that we put out that showed us this. I want to just show you a couple of things that were really impactful for us. First is looking at the role of fentanyl. And we looked at fentanyl being responsible for most of the deaths, and a real focus then on understanding fentanyl, but understanding that addiction is a polysubstance disease, and you could see all of the other drugs that were involved as well in somebody who died from an overdose. Next, we said, who is at highest risk of dying from an opioid overdose? If we're being asked to decrease the overdose deaths in Massachusetts, how do we know that if we don't know who's at greatest risk for dying and find ways to intervene before they get to that point? So how can we move upstream from overdose deaths to really being able to engage someone? So we started looking at different populations, and we found some striking findings. Again, using the data to unfold and quantitatively put forward what we need to know to address what we know were disparities. I knew from my clinical work that there were disparities, but how do we quantify that and then take that and change it into actionable health policy? So first example, individuals with a history of incarceration. We found that if an individual who is using substances had a history of incarceration, their risk of death was 120 times higher than others, one of our highest risk groups. And yet we had very few programs focusing on individuals with a history of incarceration. And what we also found behind this data was that that risk was greatest in the 2 to 4 weeks after they were released. Right after they were released is when their risk was highest. We took this information to the sheriffs, to the Department of Corrections, prisons and jails, and after a long process, we're able to change the way that we think about individuals who are incarcerated and their access to treatment for substance use disorder. Second example. Individuals who are experiencing homelessness. So people who are experiencing homelessness, very difficult from a data point of view to find people who have experienced homelessness. We worked on a process to do that and saw that individuals who are experiencing homelessness had a 30 times higher risk of dying from opioid overdose. So programs need to focus on those individuals who are experiencing homelessness. We also found that that treatment for medications, so treatment with medications, so medications for opioid use disorder work. They work to make individuals decrease their risk of opioid overdose death. In fact, almost a 50% improvement. Think about that, 50% improvement. What cancer drug could do that? And yet, at the time that we did this survey, this is 2011 to 2015 data, less than 5% of individuals when presenting with an overdose in Massachusetts, where we believe we provide the highest quality medical care than anybody in the country, or maybe we think the universe, but less than 5% were getting medicine for opioid use disorder. This helped us work with our medical colleagues to really change the access points for where medication would be available for individuals with overdoses. And then we saw that the co-occurrence of serious mental illness and opioid use was a high risk for opioid use disorder. And finally, in pregnant and postpartum women, we had many programs for pregnant and postpartum women. We were proud of them. that followed women during their pregnancies who were using substances and shortly thereafter. What this data showed us by integrating this data is that actually the greatest risk, that orange line, was in the 6 months to 1 year after delivery. What did that mean? Our programs that were stopping at a few weeks or a few months needed to extend out. So here I'm giving you really concrete examples, and I'm stopping here to say we used the data and we said, what can the data tell us to find out who's at risk, and then very concretely change policies at the state level based on that data that we were finding. And with that, we found that we did start to see a stabilization and decrease in the opiate overdose death rates in Massachusetts. And we projected out that if we hadn't seen that stabilization, the dotted line is the rate that we would have seen increased opiate overdose deaths and what we stabilized to see. Many of you who follow this topic may know that unfortunately we have fallen behind again related to the COVID-19 pandemic, but there's work going on to continue this. As we talk about racial equity, there's one group that we were never able to impact change in. So before we started doing this work with the data, surprisingly, the data, maybe not surprisingly, the data had never been satisfied, never, at the Department of Public Health by race and ethnicity. So we started to do that. It's easy enough to do, it's collected, but we had never stratified it or presented it publicly. And what you can see here in short is with all those successes that I just showed you, almost every group had a decrease in opiate overdose deaths. And this is where it's really important for those of us working in health equity to be intentional and to say, we will not stop at saying overall the deaths have decreased. What are we missing? Where are the gaps? Where is the data pointing that we still have work to do? And you'll see here, devastatingly, that the only group of individuals who still had increasing opiate overdose deaths were Black men. And this then allowed us to focus our efforts at a population level and an individual level for those, and to figure out what is it in our services that we now provide that are not reaching you and not allowing you to access this opportunity for health. These are the and exercise and calmness. These are the priority populations that came about from this overdose work that we did. I just mentioned all these to explain to you in a little bit of detail. We then started looking at data beyond substance use disorder. And maybe to no surprise to folks in this room, it didn't matter what the disease were. Many of these groups were still the ones who had the highest data disparities when you looked at outcomes. So we flipped our model at the Department of Public Health, and we said, instead of going disease to disease, grant to grant, program to program, let's focus on the people. Let's focus on the people who are at highest risk and plan our programs so that they are the ones who are included in every way that we can. And how do you do that? Again, what was our lever at the Department of Public Health? We procure out millions of dollars in grants that go out across Massachusetts. And we put in as one of the requirements that you have to address one of these groups in whatever way that whatever part of the Department of Public Health work you're working on, whether that's gun violence or diabetes or congestive heart failure or mental health. And if you don't, there has to be an explanation to why. So we built it into the system to focus on priority groups that we knew were at highest risk in order to start to decrease those health inequities. We built this into a racial equity as a public health issue roadmap. You can find things about this online, and we made public health, racial equity, a public health issue at the Department of Public Health, and I'm proud to say that just recently, the current Department of Public Health has at a state level made public health, has made racial equity a public health issue. Many of you, I hope, will go on to run systems as you go on in your career. And I want you to think about, how do you make it clear for the people you're working in? This is a system that we designed with that Department of Public Health house of how we will, in each place, in our priorities that I was sitting as a commissioner, in our state health priorities, in our priority populations, how we would drive towards health equity and how it connected to everybody's work at the Department of Public Health. There are 3,000 employees at the Department of Public Health, and we wanted everyone to be engaged in this work, again, intentionally. Then COVID came. When COVID hit, I had been at the Department of Public Health for 5 years. I opened by talking about relationships. It was really key for me that I had been there for 5 years, understood the system. And when we had to go into action, we said, how do we continue? We were in crisis mode. It's a whole separate talk that maybe Professor Bharel call me to talk about it another time, about our response to COVID. I want to just talk about a few pieces of it as it relates to equity. Many times when our systems go into crisis, think about a crisis that you've been involved in, whether it's a health crisis or other. We all go to our basement emotions or our basement ways of acting. And what we wanted to do at the Department of Public Health is say, remember, we have a framework for this. When you blanket response as a policy across an area, in this case across a state, you will worsen disparities unless you pay attention intentionally to what those inequities are and how to measure them and address them. This is 2020, from March to April, cases soaring, trying to keep the hospitals open, trying to keep as many people as possible safe, having to make really tough decisions about closing schools, keeping people apart from their loved ones in places like nursing homes and homes. During this time, we went back to the Mass Department of Public Health House and said, how do we get the data we need to make sure that as we do this work, we continue to focus on those who need our services most? In a public health pandemic of our lifetime, unless we are conscious about the inequities, they will get worse. And many of them did, as you know. One of the first things we did in April, in the beginning of April, through a executive power that we had, again, looking at the levers that we had, we said that when you report cases, COVID-19 was required reporting. When you report it, you must report with race and ethnicity. Up until then, by the way, communicable diseases were not, there was no requirement for race and ethnicity to report it. If we believe that there's going to be an inequity in COVID cases, hospitalizations, and death, like there is with every other major illness, as we showed going along, if we believe there's going to be inequity, how are we going to figure it out if we don't measure it? So you'll see here that the deaths, cases, and hospitalizations, as soon as we made it a requirement, started to increase, and it allowed us to measure the disparities so that we could then target them. We saw, unfortunately, that the rates of positive cases were highest in Black and Hispanic residents. So if you look on the left-hand side and you just look at crude numbers or you look at rates, you might not catch this. Excuse me, if you look at just crude numbers or percentages, you might not catch it unless you compare it to the rates, right? And then you see in cases, Blacks and Hispanic residents, the highest numbers. In hospitalizations, Blacks and Hispanic residents had the highest number of cases. And then unfortunately also in deaths from COVID-19. And you know this played out across the country in various different ways. And so by May, we developed a COVID-19 Health Equity Advisory Board to help us say, we're not doing what we intended to do here. These data disparities are widening. What do we need to do? How do we engage the community in order to turn this around? And with that group, we came up with multiple different interventions. In the interest of time, I'll talk to you about, again, intentionality. We looked and we saw that the cities with the highest COVID-19 rates were primarily our communities of color. So we needed to address this with a racial equity frame. And we put focused resources at the community level in these communities as a health equity initiative. We went to the community and in a first ever, during COVID in 2020, interviewed 35,000 individuals, overrepresenting for people who usually don't have access to this kind of interviewing. And we did that in partnership with community-based organizations so that these interviews could be done in multiple different languages at homeless shelters so that we could engage people who may be less willing to participate in a state-run survey like our LGBTQ+ youth through the community-based organization so that we could understand what the needs were and really then target and hone in on those. That led to our data-driven approach to community engagement and vaccine equity initiatives. Again, this is an example I give you of using the levers that we had at hand with always a focus on intentionality towards health equity. And in all of our positions, whatever they are, Whether you're a student or you're running a health department, there are levers that we have in front of us that we can use to intentionally improve equity. I included this photo because I took it almost 4 years ago, where we really needed hope and an understanding. And I'll tell you, being at the Department of Public Health during COVID, it was like no other experience. And even though there are a lot of things that didn't go right, it shone a light on what we needed in public health and public health infrastructure in Massachusetts and across the country. And the people who are the true heroes in our healthcare and public health and government systems, I can't tell you how much of themselves they put into this work. And over the 2 years of the most emergent part of the epidemic, it was 20+ hours a day without any weekends, without any opportunity to, bake sourdough or go through their closets. I mean, these were people who are on the front line, really giving. So optimism and hope, because there are people who are trying to do the right thing every day. You heard in this series from Dr. Ojikutu. So I'm going to just briefly, in the interest of time, say that this same approach is what we used in Boston when we were looking at, thank you, it's a true friend. This is the same approach we used in Boston when we were looking at the issue of unsheltered homelessness and helping Mayor Wu as she prioritized. We collected data and we used that data connected with the narratives of individuals to get people out of risky situations like this. Again, there had to be intentionality and a public health-led approach to go from this to this, where the program was implemented, and we then were able to develop a long-term plan for addressing issues for people experiencing homelessness with the city, which they are now implementing. I finally want to bring this full circle and talk about the work I'm doing right now. I work at Google now. I've jumped to another sector. So I went from healthcare to the public sector and government, and now to private industry and technology. And at Google, I'm working on finding ways to take technology and the technology innovations at a place like Google and help the public sector use those in ways that improves innovation and equity. And when I talk about intentionality, unless there are people in spaces like that thinking about public health, public sector, and the different ways in which things need to be designed and used in order to reach equity, it won't happen. So just to highlight for you 2 areas I'm working in. One is, remember I gave you that example of the public health data warehouse? Massachusetts is still one of only a handful of states who looks at the data in that way. There are tools available that technology has designed that can make it easier for states to be able to do this, for countries to be able to do this. And that's one of the areas I'm working on so that we can more holistically and quantifiably be able to pull this data together. Second is looking at generative AI. Generative AI, I won't do it justice here, but generative AI has potential to help us in the area of health equity. But we, those of us in this space, need to very thoughtfully think about where those spaces are and how do we get our technology partners to invest in these areas, whether it's improved communication, organizational competencies, or novel insights like the ones I gave you concrete examples of. And finally, I gave you a lot of data. This is, I love Maya Angelou. This is one of my favorite quotes from her, and it's about relationships. This patient of mine, by the way, any patient photos here are with permission. This patient of mine said, please use this, he's passed away now. His name is Frank, and he said, please tell people my name and use this freely because I want to live on. So we can learn to see each other and see ourselves in each other and recognize that human beings are more alike than we are unalike. So we take the data, we tie it together with the relationships, with the passion that all of you have. For the students in the room, I have great expectations of where you will take this work, how you will move it forward. But there are levers all of us can pull. In a world where there seems like there's lots of issues that are overwhelming and difficult to fix and a lot of differences, there are ways that we can each take one step forward. I should have said this in the beginning, but I was focused on my technology pieces here. The views that I'm giving here are my own and not those of my employer or anybody else that I have worked for, but I'm happy to share them with you. And with that, I think I've only left a few minutes, but really appreciate your time and open to any questions you may have. Thank you.
Thank you so much for coming to North Eastern and sharing your work with us. I think your work really highlights the importance of relying on data, more importantly, socioeconomic and ethnicity data to inform us and also inform help us to react quickly and act on at the population at the local level. We have some time for audience questions. So anyone in the audience would be interested? There's a student over there.
Hi, thank you for everything. So I was really interested when you started talking about your interaction with the patient and how she told you if she had the ability to eat the proper fruits and vegetables and get exercise, then she would have better health outcomes. And I think we learn a lot about that in public health right now. And so my question is, how, as the Commissioner of Public Health, did you address the risk factors for cardiovascular diseases and kind of like the major leading causes of death in the United States at a preventative level, specifically in public school systems? Because I think that that's where it starts. My name is Ava.
Now it really doesn't want to go. It's like done. The time is done. No, now. Oh, there we go. Ava, thanks for your question. Ava, thanks so much for your question. You're asking a series of important questions. So one of the things is that I'll go back to the Mass Department of Public Health House. So in all of our programs, it's about what data do we have? How does that connect to the social determinants of health? And how do we find existing disparities? And we have programs at the Department of Public Health that specifically work with public schools, including health services that are embedded within the school. And I worked very closely when I was over the school nurses to look at some of the work that could be done for prevention. I must say that one of the challenges in public school systems, and it sounds like you're interested in this, is that there's a lot of crisis-based care. And so going to prevention has been challenging, but there's a lot of interest in that area. And I would say going towards, looking at the data and disparities and taking that as a target to say, how can we go upstream of that is one of the ways to engage. But there's a lot of interest in education and engaging the education and health connection.
I'm Jay. Just a question I have for you is what is it that we need to do? What are the competencies that we need to make sure our students are coming out with to be able to support the work that you're doing?
Yeah, thanks for that question around competencies for students. I think it's fabulous to have series like this. For students to understand that there is a potential to work across disciplines in a way that can be impactful, I think, and to model leadership. There wasn't as many examples when I was a student of ways in which you could be a medical doctor, for example, and then also work in these areas of health policy, and that's changed. That's changed, even to Ava's question is, education and health working together. So I would say in a university and graduate level, how can we teach our students to be really good stewards of data and understanding how to use our data to be able to then connect that to actionable policy insights, number one. And number two is working cross-discipline. Some of the most important work that I did, for example, I gave that example of the incarcerated individuals. We wouldn't have been able to do that if we didn't go cross-discipline outside of health to corrections. Thank you.
So I'm Victoria. I had a question regarding your research. So you translated the health disparity into numbers, which you then use, to drive your policies forward. I was wondering how you incorporated the actual numbers and the evidence behind it in order to establish that health disparity instead of just looking at a chart. How you took that chart and put it into programs, how you put it into reforms. To make a difference instead of just acknowledging that there's a disparity and fixing it.
Yeah, I think, so the short answer to that depends on the situation and it depends on the circumstance in which you are. I would say that any of you who are researchers to think about, when we publish something and we get it into a journal where, we're academic and we're so excited and got into it, but how do you take that and make it actionable? And are there ways you can then help highlight that? In academics, we don't think about, how do you get it into the local paper? So that people who are maybe outside of your academic circles are hearing and thinking about it. How do you write a blog? How do you post about that in a way that maybe someone in education, to Ava's example earlier, will see that and make a connection to that? And I think also to have visuals and simplified ways of speaking about things so that people outside of our own fields can grasp onto it and connect it to something that they're working on. In the example I gave you at Healthcare for the Homeless, because the state was looking at ways to bring down healthcare costs, that was a way to connect services that we were looking at to go upstream and to enhance care when we talked about the cost of care. So again, that gets back to this lever of what is the lever in front of you and what are the constituents on the other side of the table interested in, and how do you connect your work to that? Because many, many of us have dedicated our life to improving justice and fairness in health, but not everybody has. But we can connect around the work that others are trying to do to make that connection and link it to, economics or education or other places where we then are lifting up our own work in health equity.
Okay. Hi, I just had a question, regarding like your clinical work beforehand going into the world of like public health. How do you think it could be, or if it could be helpful to go from like a more clinical approach, like practicing medicine, something I'm interested in? Like, how do you think going from that approach and then kind of going into more like policy making and like government could be more like, how did you like make that transition?
It's a great question. The question is about how do you move from clinical work to policy work? And honestly, when I was doing my clinical work, I wasn't intentionally trying to work on policy. It came naturally as I told the story that I did. I think that there are more opportunities now. To go from that, I would say that, practicing clinical medicine is an all-in effort. And when I was doing that, and when I was a student and when I was a resident and I was early in my career, my focus was on being the best doctor I could. And in those situations, there are opportunities to make policy change with a small p, right? So policy change doesn't have to be, I changed a policy for the whole state or the country, or, right? There are ways that you can impact policy in your clinic or in your healthcare system that begins to then have you see the ways in which you can do that.
Thank you so much. We have to wrap up for the in-person activity here, so I want to invite everyone to share a round of applause for Dr. Monica.
Thank you.
Now we're going to take questions from the Oakland campus. This will be online, and everyone should feel free to leave the building.
Thank you. All right, so I'm gonna try to see if we can do this. We're gonna stop sharing. Yep. Go into the.
John Lowry. I'm a affiliate in the health sciences group in a business. I work on.
Go interdisciplinary.
Exactly.
Where'd they go?
I work on like food bank partnerships with healthcare organizations.
Here we go.
So like screening for social terms that are coloring out. So like food bank those kind
For
of.
those of you who are online, we're shifting over to online so that questions, so that you all we can try to answer the questions that are in the chat. But then also, if there's the students, I think Maya is the TA that is helping with questions from the Oakland campus. So I don't know if people want to unmute and ask questions, they can, or if they want to put them in the chat, that they can.
We didn't even get to talk about rate space.
Maya, are you there? I don't know if you're there, Maya, if you're hearing us.
Yes, I am. Hello, good morning.
Great. It's a little hard to hear, but I don't know, it might be easier to have people pop them in the chat, or if they have a question, they can ask. If they don't, that's fine as well. We just wanted to make sure people had the opportunity.
Yes, I think there are a few questions in the chat, and that would probably be the easiest.
Okay, so you're gonna pop some in the chat?
Yes.
Great, that would be perfect. A couple of people in the room are talking to Dr. Burrell, so as soon as we can get that sorted, she'll jump on and answer some questions. So have them pop them in the chat and we'll go from there. So there's a bunch of folks online, a class online, and they said that they would try to put questions in the chat
Okay.
that you could answer. There was a the lunch crowd. So there was one question here from Rich Cornell. He's a professor. And then others were waiting to see if they're gonna
Do you want
pop
me
in
to
the
try
chat.
and start answering?
But you can feel free to start answering and then I'll come back.
Hi, thank you so much for joining online. I hope you can hear. Professor Cornell, I think you had a question about the Health Policy Commission. And I will say that, yes, I have worked with the HPC. And there is some work happening there as well to bridge between social determinants and health. And we did some work actually together while I was commissioner. So it is, again, another lever to pull in this important work.
Yeah,
So
I
thank you.
was just wondering, I mean, first of all, thank you so much. This was an incredible talk and, you know, you're very inspiring. And very positive, which is excellent. I'm just wondering, you know, sometimes having worked in the healthcare industry, sometimes the dots don't get connected, right? But it sounds as if you have had some experience with the Health Policy Commission. And, you know, they seem to be very active and, you know, it's relatively new, I think, in the Boston and Massachusetts health world. And I think that they're doing some great work. I just want to make sure, you know, as you say, can you pull that lever? Can we help pull that lever? Can we bring that together? So that's all.
The other thing you're bringing up, I think the other thing you're bringing up, which is really important, is that there is this junction between healthcare and public health. And there's a intersection that, you know, I feel like in many ways, public health is working parallel to healthcare when we should be working in a more integrated way. And it is possible. During the COVID-19 pandemic, we had much more collaboration across public and medical care. And there's ways in which that we can collaborate better in a way to strengthen our work together. And so that we are not duplicating services and duplicating along the spectrum of preventing illness and then treating illness and getting people access to illness and then how they live in their communities in recovery. There's much more work that can be done. And I think COVID-19 showed the art of the possible there as well.
I totally agree. I worked for several years at the Brigham before coming to this position at Northeastern in the, you know, as an administrator. So, you know, my sort of thought is that, you know, people are so focused in the hospitals on providing care, right? And as you were earlier in your career. So, and then you have another group of people that are so focused on public health policy and looking at things at a higher level. We have to make sure that they're communicating. And I thought that, as I said, you're very inspiring in that regard. Thank you.
Thank you. Thank you so much. And thank you all for joining online. If there's anyone else who wants to raise a hand, otherwise, I'm happy to wait for another minute if there's anyone else who had a question. Otherwise, thank you so much for joining online. Really appreciate your work and wish you all the best in the future. Take care.
Oh, I had a quick question, if that's okay.
Yes, Samantha, please.
Yeah, so I will be graduating in a couple of weeks here on the Oakland campus, and I wanted to know kind of how you got to where you are, what were the steps you recommend taking, or what are the steps that helped you in your career?
Yeah, thanks for the question, Samantha, and congratulations on your upcoming graduation. You know, a
Thank you
question
so
like
much.
that came up in the room as well. And what I would say is, you know, for me, and there's different paths that people take, but for me, it was around figuring out what my passion was and my vision. And that was, and making sure that any work I did aligns with that. So for me, that is around justice and fairness in health. and ensuring that my focus is on justice and fairness in health. And as I did that, my clinical work, it naturally, through curiosity, through engagement, through, coming to talks like this, I think it'll help you find your path. Best of luck with you as you head towards graduation.
Thank you so much.
Thank you, everyone. Take care. Thanks again for joining.
Thank you.